my discussion on Thursday at the meeting was on the difference of different immune therapies in non-small cell lung cancer. So different immune therapies which disinhibit the immune system to allow lymphocytes to attack lung cancer has revolutionized the treatment of non-small cell lung cancer. At first, we were using these immune therapies without selection of patients or using any biomarkers in previously treated patients, patients that had already had chemotherapy for their lung cancer. And then, since then, the field has advanced so that we can test different biomarkers, particularly PD-L1, which is a protein that is expressed on the cells of some tumors. And it's been learned that if the tumor cells in lung cancer and some other cancers have a high expression rate, if most of the tumor cells express the PD-L1 protein, then that is a marker for a high likelihood of responding to immune therapies. That would include nivolumab, pembrolizumab, atezolizumab, and durvalumab in lung cancer. And for some of those immune therapies, it was shown that for these high biomarker group lung cancers, you can treat with single agent immune therapy and get a better outcome with less toxicity compared to chemotherapy, which had inferior outcomes and worse toxicity. And then more recently, we've been looking at combined therapy in the treatment of upfront disease where patients were treated with chemotherapy plus immune therapy. And that is now broadly applied in non-small cell lung cancer, such that pretty much all non-small cell lung cancers are eligible to receive chemotherapy plus immune therapy. There are some exceptions. So there are molecularly targetable lung cancers where we test for certain gene abnormalities, mutations, or translocations in particular targets like EGFR, ALK, ROS1, and they receive an oral molecular therapy first. So we've pretty much gotten to the point where for most patients, we can either treat them with an oral therapy that's effective and less toxic than chemotherapy, immune therapy alone, or chemotherapy plus immune therapy. There are exceptions around using immune therapy in patients that have autoimmune diseases. So for people who have diseases like psoriasis and lupus and rheumatoid arthritis and some other diseases that would constitute a hyperactive immune system, that limits our ability to use immune therapy in those individuals. Although we do have clinical trials now going on in the United States and elsewhere trying to study how safe is it to give immune therapy to these patients. Several decades ago, almost all patients would receive some fairly non-specific chemotherapy if they had an advanced cancer. The only exceptions were really giving hormonal therapy for patients who had breast cancer or prostate cancer, and then early on being able to determine certain molecular markers that created diseases like chronic myelogenous leukemia. But other than that, treatments were largely just very non-specific, what we call cytotoxic chemotherapy. But since the 1990s, there's been a rapid identification of different molecular alterations that can happen in cancers that allow us to target the cancer specifically with a therapy that may be specific for that molecular alteration that can often be highly effective and less toxic than chemotherapy. They're not present in all cancers. You know, unfortunately, we don't find molecular targets in all cancers where we can offer some sort of a precision medicine sort of option, but more and more we're able to identify particular molecular abnormalities that tell us that a cancer will be susceptible to a less toxic molecular targeted type approach. We're not where we need to be in the treatment of any of these advanced cancers because we're usually not curing people. Although I think that in molecular therapy, we are having patients, rather than live months, are now living for years and years with a good quality of life. I just came from a talk that was on Parp inhibitors in breast cancer and ovarian cancer, where for women whose cancers are driven by BRCA mutations, dramatic results with Parp inhibitors in addition to standard therapy. In lung cancer, that's my area of specialty, we have oral therapies against EGFR, ALK, ROS, and a rapidly expanding group of molecular subtypes that allows patients to live for years with good quality of life rather than just adding on months with chemotherapy. With immune therapy, we're having durable responses where patients may have control of their cancer for years in immune therapy. And I think most people that work in the field feel that they have a small percentage of patients who may even be cured by immune therapy. But now we're moving on to combinations of immune therapy and molecular therapy that we think have promise to increase the number of patients who are having dramatic long responses to treatment, and ultimately will have the potential to cure the cancer. There have been approaches in blood cancers, like B-cell leukemias and other approaches, where to actually take an immune cell, give it a receptor against the cancer, and then activate it, sort of this CAR T-cell therapy. Mostly that's been a little too toxic for various reasons in solid tumors, but the technology is rapidly expanding to try to get around those toxicities, so we may be able to develop cellular approaches to therapy. In other words, taking cells out of the body, arming them against the cancer, and then giving them back. That's one of the major focuses of our immuno-oncology group at our Duke Cancer Institute. So I think that holds a lot of promise also in solid tumors.